Renal mass is what the surgeon needs. First, what is our goal of imaging? First is, usually you will get a lot of lesions which are incidentally detected on ultrasound, right? You want them to characterize whether these are benign or malignant. Second, if you have a malignant, the surgeon wants to know certain information from you, and you need to give them that. Now, what to do? An ultrasound, CT or MRI. Again, CT is the workhorse. CT is what usually we do in day-to-day practice. MRI is reserved for a very small cases as problem-solving tool. So, your approach should be, first, whether a lesion is normal or abnormal, whether it's benign or malignant, solid or cystic. If cystic, it is complex or not. So, cystic lesions I'm not dealing because Dr. Baum has already covered. Now, first is a pseudotumor. That means if you see something and it is not a mass, how do you identify what are these lesions? Common examples are prominent columns of Bertini, dromedary hump. Let's see some examples. So on ultrasound, we found this kind of hump in the renal contour. My resident told me, I can feel there is a mass. We were not very sure. We took the patient on CT scan, we gave contrast, and you can see this was nothing but a prodromery hump, which is a congenital physiological variation. You can see it is taking up the same contrast as the rest of the kidneys. We were confident. Similarly, another case, prominent columns of Bertini. You know these columns are normal anatomical structures, right? But when you do a CT scan, you can see in the nephrogenic and the corticomedullary phase, they're exactly the same as the native kidney. So you're very confident that this is not a mass lesion. So do not call a pseudo lesion a mass lesion. Right. Another case. So this patient presented with these kinds of hypodense mass lesion. Again, my resident said that he thinks there are multiple mass lesions. Unlikely. Bilateral mass lesions, yes, they can be, but it's unlikely. Then we took a history. The patient was having fever. His counts was raised. This was nothing but areas of renal abscess which subsided after a course of antibiotic. Right. More examples, renal abscess. You can see renal abscesses will have fat stranding around them and will have a very typical history of pain, fever, and raised counts. Right. Then you can have some misleading entities like lymphoma. Now, lymphomas can present as bilateral renal masses. However, primary lymphoma of the kidney is very rare. Usually, they will be accompanied with hepatosplenomegaly, lymphadenopathy, and in this case, as you can see, destruction of the pelvic bone. Also, B-cell and Burkitt's lymphoma at times present like this with a peripheral limb of collection around both the kidneys, and they will of course show hotspot on the FDG PET. Okay, now once you are done with the solid and the cystic, once you are done whether the cyst is simple and complex, conventionally the renal carcinoma is divided into two shapes, that is the ball type lesion and the bean type lesion. So ball type lesions are lesions which are exophytic, which basically arise from the cortex and are going out. These are the clear cell type, the commonest type, and then they are the bean type lesions which do not change the architecture of the kidney per se, but they will infiltrate into the collecting system. This is the transitional cell type. So this is just, the conditions which you can have in ball and bean type. Right. Now what is this CT renal protocol? Right. How do we do it? First, we take a pre-contrast, right? Then you take an arterial phase. Why do you need an arterial phase in a kidney done for renal mass? Because you need to tell the surgeon about the renal anatomy. If there is an accessory renal vein, if there is an accessory renal artery, if there is an anomalous origin, you need to tell these things to the surgeon. So you need an early phase. That means between 20 to 30 seconds, you need an early phase arterial. Then you need a corticomedullary phase, right? And then, which is about 40 to 70 seconds. Then you have a nephrogenic phase, which is at 100 to 120 seconds. And then you have an excretory phase in which the contrast comes down to the ureter and then to the urinary bladder. Now, each phase has its own importance. Unenhanced phase is used for the detection of fat, calcification, hemorrhage, and proteinaceous fluid. Corticomedullary is to differentiate tumors from pseudotumors. Nephrogenic phase is the most important phase which tells us what is the cell type. We will see it later. Excretory is done to see and locate small transitional cell carcinomas. Right. Starting with the first most common type, that is the clear cell carcinoma. This is the most common type. This tumor arises from the renal cortex. It is often expansive, heterogeneous. It shows very good contrast enhancement. It may contain both calcification and fat. This may be bilaterally symmetrical. So that's a CT scan. So that's how it looks on unenhanced, on corticomedullary, and then how it looks on nephrogenic phase. So if a cancer is very small, clear cell carcinoma is very small, on nephrogenic phase it will show less enhancement than kidney, while in the corticomedullary phase it will usually show more enhancement than kidney. Now this has a very poor prognosis. 75% of all carcinomas are clear cell carcinomas. That's a case of advanced clear cell carcinoma. Unenhanced images. Oh, you cannot see my marker. Excuse me, can you put the marker? I cannot show them. The marker is not coming. So the first image is unenhanced scan. The second one is an arterial phase where you can see, yeah, thank you so much. The second one is an arterial phase where you can see the tumor filling in the full of the kidney. And then if you look carefully, where is the tumor going? The tumor is going slowly into the renal vein, and then through the renal vein, it is going into the IVC. This is so important. You need to give this information to the surgeon. And not only that, look, the tumor is enhancing. So the renal vein does not have a bland thrombus. It has an enhancing thrombus, which is a tumor thrombus. Also, the patient had multiple metastases in the lungs and the skull bone. Okay, so this was a very, very small renal cell carcinoma, which we picked on, which you can pick on MRI. So look how small it is. On T2, it is hyper intense. On T1, it shows good amount of contrast enhancement. And what is this? This is in phase and out phase. So in phase, it is hyper. Out of phase, it shows hypointensity. That means there is microscopic fat. So if you have a mass lesion which is showing enhancement, which is showing fat, unless otherwise proved, most probably you're looking at a renal cell carcinoma, clear cell variety. Next case. The second most common is the papillary RCC. Now these, though have better prognosis than clear cell, though being less common than clear cell, they can be very difficult to pick up because they look more like cysts. You might miss them as simple cysts and they might turn out to be papillary carcinomas. These are more bilateral and more multifocal. Right, so this is what we picked up on ultrasound. An echogenic isoechoic mass lesion. We took on ultrasound, on CT scan, on unenhanced CT scan. It looks like a cyst, maybe like a complex cyst. We gave contrast. There was not at all much enhancement, very less, maybe 15 Hounsfield unit. We were not sure whether this is cyst, whether what is this, a complex cyst. We took the patient to MRI. Now look what happens on the MRI. This is a T1 scan. This is a T2 scan. On both the sequences, the lesion is hypo. Now you know a cyst would be hypo on T1 and hyper on T2. But this lesion is hypo on both T1 and T2. That means this is not a cyst. This is a renal cell papillary type of carcinoma. Again, a very small renal cell papillary carcinoma. T2, nothing. Looks almost like a cyst. Post-contrast, not much enhancement, but when you give diffusion restriction in ADC, it restricts. That is one more characteristic of papillary cell carcinomas. They restrict on diffusion restriction, though they do not show much enhancement. The third most common type, which is not really common, 5% of the whole lot, is the chromophobe cell type, which is intermediate. It shows some amount of contrast enhancement. It shows some amount of diffusion restriction. Remember, these are very close to oncocytomas, the benign entity. Right, so where you have a T2 isointent showing minimal enhancement and some amount of diffusion restriction, so you can say that it's a chromophobe. Right, so what did we sum up? Clear cell RCCs, they will show a lot of enhancement. Papillary, they will show less enhancement, but they would be hypointense on both T1 and T2 on MRI, and chromophobe would be intermediate. Then you have the benign entity of angiomyolipoma, which is very easy to pick up. So these will have lot of, this is the most common benign solid renal mass, and these will have lot of calcification, lot of fat, lot of necrosis, really easy to pick up. Only if they are very small, it could be a problem. So that's a fat-rich AML where it shows fat suppression, and you can see the ink artifact in out-of-phase imaging. Coming to oncocytoma, which is again a common benign solid renal tumor, you know how to identify. They are really large at presentation and they will have a central stellate car. It's extremely difficult to differentiate them from chromophobe, and even the pathologists usually cannot differentiate. Transitional cell carcinoma. And transitional cell carcinoma per se, it's a bean-type lesion which infiltrates the pelvic ileal system. Now, these are notorious for spreading along the urinary tract. So, if you see a small foci of carcinoma in the collecting system, make sure you see the full ureter and the urinary bladder, because they might be somewhere else. One more issue which you have with these carcinomas is that you cannot take biopsy. You cannot take a subcutaneous biopsy because these have an extremely high rate of seedling. So, you have to be extremely careful. Now, you have made a diagnosis of a renal cell carcinoma. Now you need to give the staging. Now, the T stage consists of the size. Anything less than 7 centimeters and limited to kidney is stage 1, further divided A and B less than 4 centimeters or more than 4 centimeters. T2 is anything more than 7 centimeters but limited to the kidney. Again divided into A and B. A is less than 10 centimeters, B is more than 10 centimeters. Stage 3. Stage 3 is any mass which goes beyond the kidney, right? That means you will have to look at perirenal spaces, the perinephric fat, right? And if there is an involvement of the renal vein, do not forget to mention the renal vein in detail for all your renal masses, right? Not only you have to say the extent where it is going, infradiaphragmatic, supradiaphragmatic, you have to also, absolutely be very clear about the extent for the surgeon. Then, what is stage 4? Stage 4 is everything beyond the Gerota's fascia, or if there is involvement of the adrenal gland. Apart from this, of course, you have to tell about lymphadenopathy, metastasis, and liver or bone. Right, so that was sort of a sum up of, even if you cannot give a proper stage, it is perfectly okay. The surgeon will know what to do, but you at least tell them the size, the level of involvement of the renal wall, whether the involvement of the renal vein is supra or infradiaphragmatic, and these things. Okay. I'll just take 2 more minutes. So pre-op planning, when the surgeon sends to you before surgery, so what the surgeon will do is he will either do a partial nephrectomy if the mass is really small, or he will do a total nephrectomy, or he will open up, or he will do a laparoscopic. Now you need to give something known as renal nephrometry score. So when I was a resident, we used to take pride in writing long reports, right? That the mass is going anteriorly, posteriorly, laterally, medially. Those times have changed. Do not clutter your report with unwanted information. Give the information which is required to the surgeon. This is a renal nephrometric scoring which ideally should be given in all mass lesions. What is this? R for radius, E for exophytic or endophytic, N how close is it to the collecting system, A is whether it is anterior or lateral. You even have a Google app for this. If you just go into the Google app, you type in renal nephrometry score, you will get a Google app where you can, fill in and they will give you the score. So what are these one by one? Radius, pretty easy. You just have to give the size, right? Whether it's more than 7 centimeters, whether it's between 4 to 7 centimeters, whether it's less than 4 centimeters, and then you give a score of 1, 2, 3. Then you have to specify whether the lesion is exophytic or endophytic, right? And then you have a score. How much is it exophytic? Less than 50% or more than 50%, right? And then you accordingly give a score. Then nearness to the hilum, very, very important. How close is it to the hilum? Again, you give scores accordingly. 1, 2, and 3. Is the lesion anterior, near the anterior pole? Is the lesion near the posterior pole? Or is it neither between the anterior or the posterior pole? Then you draw what is known as the polar lines. You take the superior-most part of the pelvic ileal system and you take the inferior-most part of the pelvic ileal system, and then you divide them. So you take 3 lines and you have to tell the surgeon that whether your mass is entirely above or below, or the mass crosses the polar lines. If you can do this, believe me, your surgeon will be more than happy with your report. We have been doing this for some time and our surgeons are really happy. Right, so concluding, a renal mass, usually most renal masses will not come to you for even, diagnosis, because Renal mass, if you have a renal mass, most probably it will go for nephrectomy. But if the surgeon sends it to you, you need to give relevant information. Thank you.